It's really my pleasure to speak to you today on behalf of Jane Hawking and all of our team who are involved with setting up this online testing service. So my presentation today is about what's needed. So I'll be sharing with you some of our process about what we've done so far, but this is equally an opportunity for me to hear from you about what's needed. How do we make this service work in rural and regional Victoria? And I wanted to begin today actually by acknowledging that it might actually be quite difficult for many Aboriginal and Torres Strait Islander people as their rights are being debated in a national forum, coming off of the gay equality referendum. That was quite hard, so I just want to acknowledge that this might actually be a tough time for some people. So in my presentation today, I'm going to take you through how our clinic is trying to respond to the limitations in current services, what we've learned about what will attract young people to use the service, the issues we're grappling with around how do we balance optimal user experience with actual feasibility concerns, and then how do we create pathways for service integration for the user from the online service into seeing local providers. This is a bit of an eccentric slide. My partner kind of made fun of me for it, but anyway, I want to begin with just what is the current state of affairs in terms of what's out there for online services. So there's a number of factors that are leading to why we're seeing a rise in offerings of online STI testing services. So of course, you know, STI notifications are rising in Australia and elsewhere. The Melbourne Sexual Health Centre is pretty much at capacity for how many more new clients they can see. As you're very well aware, in regional and rural Victoria, there's limited capacity to do STI testing. And on the other side, you've got increased demand for use of PrEP, and that's also driving demand for recurrent STI testing. We know from a huge body of research that young people really want privacy and anonymity in testing services, and that really corresponds with an online service model. And of course, COVID-19, people have really become accustomed to using online health services. And so in reviewing what we thought we would like to do, wanted to see what the main models were that are out there. So there's two kind of clear models. One is this self-sampling model. You may know SH24 from the UK. So how it works is people go online, then they get kits, self-sampling kits that are ordered to their house. They do their self-collection at home. They post those kits back. And studies have shown that actually there's been quite good uptake of this model, but it hasn't done anything to decrease that time between learning of your result and actually getting testing. The second main model is this self-navigated pathology. A popular services in Canada, Get Checked Online. So you go online, you fill out the requirements, and you get an online pathology form. Then you go to one of the kind of accredited or dedicated or associated pathology services that are related to that Get Checked Online. You go do your test there, you get your results back electronically. And the studies have shown that actually this has been quite attractive for men who have sex with men, but hasn't had as good of uptake kind of generally across the population. And so we wanted to know what was available in Australia. And one of our colleagues, Trey Cardwell, who's a PhD student in our team, he did a review, and he found there are 17 online services that you could access in Australia. They covered self-testing, self-sampling, and self-navigated pathology. And when he analyzed what was being offered, he found a number of limitations. So many of the services didn't test for all the 4 main STIs. Some didn't recommend testing at multiple sites for men who have sex with men or other recommended groups. There were non-approved tests that were being offered, and many didn't even offer health promotion information along the way. And in terms of cost, there were completely publicly funded ones, including for the self-collection kits, but there's very limited geographic, or they were very geographically restricted in terms of the users that could be eligible for those services, and of course, associated long shipping times. And then for the other routes, they went from free to actually quite costly of $600. And so the service that we're trying to design, we're trying to respond to those limitations. We're trying to build a comprehensive service that's managed by the Melbourne Sexual Health Centre for quality, and that offers kind of the suite of services from testing to treatment to partner management, and provides like a resource hub for users. And this would be offered free for Medicare cardholders. And so we are very grateful to be working with a very large range of partners, particular call out to the Department of Health and CERSH. And there are other partners here who are in this room, so thank you very much for all your active contribution to getting this off the ground. And so our bird's eye overview of the process, so we're basically designing this over a 2-year period. It's guided by participatory methodology. Then we're going to roll it out over 2 years, and then we're going to evaluate it to see what was uptake like, what were test positivity rates like, what was the user and provider experience like, and then how can we build a sustainable and hopefully scalable model. So if this service is going to be used, we've got to attract young people. So what do young people tell us? So we conducted a series of co-design workshops, and we really wanted to understand from them, what are they expecting from a service? What would attract them to a service? And what would create a good user experience for them? And so what did we learn? Well, we learned that in the marketing, the communication around what the service is offering needs to be really clear. So we should be really transparent and upfront about features like it's confidential, it's either affordable or free, and it's available online. And tone should also be positive in terms of like sex positivity. And when you look at these kind of 3 clusters of photos for, we sort of tested what the look and feel of the website should be like. So the blue section with all the clinical, mostly GPs there, they really thought that was stodgy and didn't like it at all. The kind of, I call it the brown group on the bottom, they also didn't really like that. They thought it was too intimate, and also maybe didn't actually reflect their experience, that like maybe they're not actually in these sort of long-term relationships, which that sort of suggests. They liked these kind of illustrative representational graphics, but they didn't want them to be silly. They wanted them to be informative and to kind of bring in some of that like clinical element. So a little bit of blue, but mostly the more colorful. And then they also told us that yes, they did want this to be more than just a testing service. It's a place where they could go and access resources. So that's what we know. Right now we're trying to work through the sticky bits. Like I said, we're really trying to figure out how we optimize this user experience versus feasibility. And so as I go through this pathway, these are the 6 main steps of the pathway. I want you to think about how these steps interact with your local service landscape, so particularly around those areas. So the first step, you basically go online, you answer some questions about your demographics, you provide your Medicare information, and then you answer some sexual health history questions. And young people told us that, yep, they're okay with these questions being mandatory. These would be similar questions that you get asked if you were going to see someone in person. But they wanted us to be transparent, and they wanted us to justify why we were asking for the information that we were asking for. And they also seem to have kind of in their mind and the perspective that this would be a service that you use for if you were asymptomatic. And the survey that we did also really showed that they were quite comfortable with like online only service if they were asymptomatic. The big thing we're grappling with is what do we do with people with symptoms? So most of the other service providers don't allow people with symptoms to go through, or at least people who acknowledge they have symptoms to go through. So what symptoms could we safely consider? We're thinking at this point probably urethritis. For symptoms like pain, or as Kit Fairley likes to call the rashes, the lumps and bumps, and the rashes, these probably require clinical investigation, and so we would need to refer those users elsewhere. And so what do we do with those users? Like, do those users does their service experience end there? And then what does that do for word of mouth about this service? Is there a way that we could actually help bridge them into getting clinical services instead of just kind of leaving them on their own to self-navigate? So that's, kind of something we're really grappling with, and how allowing or not allowing people with symptoms to use the service is really going to affect word of mouth and the popularity of this service. The next step, so based on the answers that you gave earlier, an algorithm will determine what tests are best for you. And then you'll get an e-pathology form. And young people told us this form's got to be electronic. If they need to print it out, the service is basically dead in the water. So we've got to make this work. And so one of the reasons that we're attracted to this, the self-navigated pathology route that I showed you earlier, is because this is kind of a financially sustainable model. So if you go do this, these services become like Medicare rebatable. And so there's no additional cost to the online service. However, as you all know, I work with many groups who don't have Medicare cards. We're not quite sure what to do. We can offer perhaps a fee-for-service model, but that also isn't going to cut the mustard for some people. So that's something we're still grappling with. The alternative is that other route, the self-collection route. And in this large survey that I did, young people from rural areas were really very much more likely to prefer using a self-sampling kit than going in person to services. But offering this to people who live in rural areas could be actually quite tricky. So we know from other services that return rates of the postal kits are really low. That's really expensive and also a lot of waste. And they're also in the Australian context not covered by Medicare. So it's not really a financially sustainable model. We'd like to continue kind of exploring, are there alternatives? You know, could we connect people to CERSH's vending machine if it happens to be in their area? Could we offer dedicated pickup and drop-off locations that other service providers would manage? These are just some of the things that we're considering along the way. Then when they get the results, so by SMS, that seemed completely fine. They did say, though, if they were positive, they'd rather the message say something like, please go online to check your results, instead of, yep, you're positive, right in that SMS. And the thing that we're finding quite challenging now is, how do we contact the people who are positive? Originally, we were thinking that if you tested positive for chlamydia, you would just continue through an online-only pathway. If you tested positive for HIV or syphilis, if you're in the metro area, the Melbourne Sexual Health Centre would manage your care, because we're not expecting a large number of cases, and then provide warm referrals to local service providers if you were further away. For gonorrhea, it's a bit trickier too, expecting a larger number of cases, don't want to funnel them all back to the Melbourne Sexual Health Centre. So what do? Do we just give them a referral letter that they can bring to a GP? Would the GP accept that referral letter? What do they need to see in that letter? Do they need the actual results? Or can we actually create service pathways where we know that there are particular providers that would be happy to receive them and actually kind of really direct them in those routes? And then I guess you may have also seen that just the other day, there's a new guideline now that people are seen on online services. In order to receive treatment, they actually need to have a consultation. So you can't just provide click and treats treatment, is what they were calling it. So that's going to be a consideration for us going forward now, also with chlamydia. And then, of course, if you don't have a consultation in any way with people who test positive, you do lose that opportunity to meet other needs and to provide other accompanying health promotion information. We will definitely be providing personalized health promotion information in written form, like that they'll get, but sometimes that is best managed through a conversation. And then the next stage is treatment. We're thinking about 3 different treatment pathways. So if you test positive for chlamydia, you would get an e-prescription to go fill at your local pharmacy. For syphilis and gonorrhea, you need an injection, so you can't do that online. So again, what are the options for those people? so that we can limit that kind of gap between testing positive and getting treatment and people who just don't continue on to treatment. As before, like how can we build those pathways? Can we involve alternative providers, so supercare pharmacies who have nurses on staff? Could they give injections? These are all kinds of things that we're exploring at this point. And then finally, there'll be options for online tools for partner notification, maybe even a link that if you did test positive, you could link have like a QR code and link your sex partners right back into the service so they could access treatment or a more expedited process. And then the last feature would be testing reminders. And again, kind of who gets this in what circumstances and how often, because we don't want to be kind of over-prescribing in terms of recommendations about how often you test. So the kind of big question is, there's less services for users to choose from when they're in rural areas. So how do we build these pathways? We'd like to select some priority LGAs in rural areas and outer metro because we do have limited capacity. We can't kind of prioritize everything with our team. And we want to build on existing investments that the Department of Health is doing in terms of establishing these sexual and reproductive health hubs. Melbourne Sexual Health Centre also has some GP partner clinics that the department is also funding to help build their capacity. So how can we work with these providers and how can we work with also like a bigger range of community providers to build awareness for the service? And so our next step is going to be a series of stakeholder consultations. So we really want to find out from basically you guys, what is the willingness and capacity to receive referrals? So for people who are symptomatic, what is the willingness and capacity to stock injections and to deliver those injections? And what would be the willingness and capacity to kind of manage those self-collection drop-off points, pick-up and drop-off points? To what extent would it be interesting and beneficial for local service providers to help promote this service, to be listed alongside this service? And how can we identify the opportunities and overcome some of the barriers together. And so that's the end of my presentation, and just again, a very big thank you to all of our partners who have helped out today, or helped out along the whole way. So I just want to